Let's talk about breast exams. So do a brief anatomy review, know your locations, how you're going to write it up, as well as your landmarks, your composition between the lobules and the ducts, as well as the muscle overlaying that adipose tissue, as well as the axilla and where your lymph nodes are going to be, and then the areola. So certain things that you want to be able to identify is basically using that clock. If you do find any abnormalities on the breast, any change or general appearance of that breast, increase, decrease in size, change in symmetry, new or persistent skin changes, nipple inversion, bilateral, unilateral, discharge, anything like that. Also note timing, color, frequency. If there is any breast pain, what the characteristics of that are, if there's any breast mass and its evolution, when did they first note it, etc. So those are all things that you are going to identify, as well as use the clock as where the identifying factor situation would be. So this is all something that you normally would be doing anyhow because it's a well woman exam, but then you're going to spay any previous breast exam issues, mammography, hormonal risk factors, BRCA1, BRCA2, breast history, all that kind of stuff's going to be more obviously concerned. If you're doing a good, thorough, well woman, you've already covered it. All right, top 3 complaints with breast is discharge, pain, and mass. And we're going to talk about what needs to be done with that briefly. Really what I want to get into is mammography. So nipple discharge, duration, laterality, stimulation, or spontaneity of it, lactation experience, what is the consistency, color, blood, purulent, things like that, and then what potential medications could be causation of nipple discharge. So you have a physiologic nipple discharge, which is called galactorrhea, and then you have a pathologic suspicious nipple discharge, which would be related to some type of pathologic process in the breast. So galactorrhea, which is the physiologic, is usually related to some type of hyperprolactinemia, could be secondary to some medications, pituitary tumors, endocrine abnormalities, and some other medical situations. So of note, some of the medications that you may see that would cause nipple discharge would be some of your antipsychotics, especially first generations, such as Haldol or chlorpromazine. Other antipsychotics second generation would be your risperidone, clozapine. Other ones would be cyclic antidepressants such as amitriptyline, nortriptyline, citalopram, pretty much any, antidepressants, antipsychotic agents. A lot of those will stimulate dopamine. And then remember that dopamine is involved in the prolactins. So dopamine is actually suppressatory of prolactin. So if we have dopamine agents, then that could potentially lead to the prolactin stimulation and release. All right, other ones, antiemetics, gastrointestinal, so domperidine, which is not available in the US, but you may have some patients who are taking it from out of the country. And then your Reglan and Compazine. Some antihypertensives would be verapamil, and then basically most of your other calcium channel blockers as well. And then some opioids as well, methadone, morphine, and your other opioids would work on the dopamine as well. So just think dopamine when you're talking about nipple discharge and if any of your meds fit there. So if we're talking about a pathologic suspicious nipple discharge, that's going to be some papilloma, duct ectasia, cancer, infections. That's where that decision tree is. Is it more physiologic versus pathologic? All right, so make sure you write those things up. So here is those things we were talking about. And then concern, unilateral, pink, bloody, non-milky, associated with a mass and age greater than 60, puts it more into the papilloma and maybe a severe infection. All right. So other things that you need to make sure, if there's breast pain, was there any previous trauma, associated lumps, nipple discharge with the breast pain, and then differentiate fibrocytic versus a discrete mass. So remember, your fibrocytic are those lumpy, bumpy breasts. All right, your breast pain differential is going to be, is it menstruation related, costochondral, which would be your musculoskeletal trauma, an unrelated cause, or cancer. You have fibroadenoma, cyst, fibrocystic changes, galactocele, fat necrosis, breast abscess are all on the breast pain differential. And then your malignant invasive would be your breast cancers. So reinforcing self-breast exams, as well as clinical breast exams, when are they due? Depending on the age, remember that less than 40, there's low risk of breast cancer development. 40 to 49, pretty much everybody is at least every 2-year testing. Your clinical breast exam, 1 to 3 is the range, so however you want to do that, it would not be wrong. And then the guidelines for mammography, which is what we're going to get into now. All right, so self-breast exams monthly, the breast self-awareness, make sure that you kind of sell that to the patient that it's very important. Remember that your self-breast exam it's not going to detect as early as a mammogram, and that is sometimes where mammography is important, because that's going to detect a smaller mass versus self-breast. I believe it's 1 centimeter versus 2 centimeter masses. So that's going to be the difference with detection. All right, so your clinical breast exam is the one that you perform on the patient as the provider. Monthly breast exam, self-breast exam is what the patient does to themselves. All right. So mammogram recommendation. So you can see here, you got a couple different groups that are going to be controlling your recommendations, and that's why it can be a little bit confusing. All right. So basically they all have a consensus, really, that anyone after the age of 40 should start receiving annual or every 2-year mammograms. So that has changed. Previously, I believe it was considered to be annually. They have kind of come back and said, oh, it's okay to be doing every 2 years if it's average risk. And we're going to talk about risk. So what I have down here is delineated by up to date, as well as looking at all of these recommendations and kind of putting it together. So the number one thing is age, and then also their risk factors. So let's take a look at the risk factors. All right, so the risk factors that potentially So what are these? These are going to be looking at risk factors. So if you pull this up and you take a look at this or print it out, so you're going to have a lot of information in here. We're going to walk through this a little bit because mammography need to understand who needs tested and why. So a number of experts have recommendations based on age to initiate that screening, as well then as understanding that risk profile. So let's talk about the risk factors. So most women can be categorized based on history alone. Others, risk prediction models are available to use if needed. We're going to take a look at one in a minute. As you can see, if you use UpToDate, they are linked, but we'll see what actually one of them is here. So major factors, patient's history are personal history of breast, ovarian, tubal, or peritoneal cancers, family history of those, your ancestry, which is Ashkenazi Jewish, or anything that is related to BRCA1 or BRCA2 mutations. So there are some higher risk ancestry that is associated with that. And then is there anybody who's a known carrier of one of those pathogenic mutations? Previous breast biopsy where there's a high risk lesion, and radiotherapy to the chest between ages 10 and age 30. So you're radiating that area for a period of time when the breasts are most developmental. All right. So you're going to take into those considerations and kind of get a risk and know where your patient falls. You could probably do this on the initial one and just keep that in the chart, because not too much of this history is going to change unless someone would test positive for something while you're working this patient up. All right. So basically age under 40, not really screening. Average risk women under 40 years of age. There's just really no data to say that it's going to be a benefit. Age 40 to 49, most experts do encourage a decision between you and the patient as to when they want to start the screening, as it is strongly recommending screening, and you need to discuss the harms and the benefits. So what are those harms and benefits? So benefits. Benefits are basically there is a 20% reduced mortality with proper screening. And this was evidenced by a group of over 600,000 multinational, multi-country systemic reviews that basically says, screening mammography was estimated to reduce the odds of dying from breast cancer by 20%. So that's quite significant. So that is the absolute benefit of screening, is that we are reducing mortality. So what are the harms? Unfortunately, there's a couple. All right. So there is overdiagnosis. And false positives. And the actual radiation itself. All right, so overdiagnosis. Unfortunately, there is about a 10 to 50% risk of overdiagnosis, which would lead to invasive procedures as well as potential treatment. So what happens with overdiagnosis is that there's really no way to determine what type of breast cancer it is. We just know that, so overdiagnosis would lead to basically identification of breast cancer that would not have caused clinical consequences in the woman's lifetime. Now that's a little bit hard to explain to a patient. Be like, yes, there's some cancer cells in there, but it's not going to grow long enough over your last 40 years to cause any problems, things like that. And a lot of people, once they hear the cancer, whether it's ductal carcinoma in situ, what age group it is in. There is that, what is that differentiation, and, is it going to be biologically insignificant? Or is there going to be clinical evidence of this cancer in the lifetime, and it's not possible to distinguish that really on the basis of how we kind of diagnose breast cancer. And usually what happens is they end up with therapy, and that local therapy, surgery with or without radiation, systemic therapy. So the overdiagnosis is basically related to the cancer may not have been clinically significant, but it led to treatment. Okay? So false positives are, for every woman who's saved by mammography, there's going to be false positives that are associated with mammography. And the women's age as well as breast density does put that risk higher. And there does seem to be about a 10% screening are false positives. And then after a decade of annual screenings, it goes about 50%. So there is related to that kind of recurrence of the mammograms, it increases the risk of false positives. So then your radiation, so there is radiation that is associated with it. You basically should tell your patients that the radiation risk is outweighed by the benefit of detecting the cancer early. And that is, it is something that, a lot of patients may have a problem with. And you just have to dispel, the fact that we could potentially reduce mortality by 20% with proper screening, and finding it outweighs the fact that the radiation may cause the cancer. All right. So those are the things that you would want to be able to talk about with your patients. And then your 40 to 49. So that's where you come with, do you want to do it yearly? Do you want to do it every 2 years? And as you can see, there's a link for frequency of screening with mammography. Risk factors may come into play with that as well. And we're going to take a look at the screening thing right now. All right, so this is the breast cancer risk tool at cancer.gov calculator. It's one of those that is included in the link. So it's going to basically look at any medical history. No. Did you have the BRCA1, BRCA2, or any diagnostic genetic syndrome? No. So we'll start low, so 40 when we start testing. They do not have the certain like the Ashkenazi Jew in there. It does say it won't let you do that though, so I don't. Maybe unknown? No, it's not letting me do that for any of them. Okay, so I would assume that there's a higher risk if you're also one of these. Let's do Hawaiian and see what happens. And then ever previous breast biopsy, first menarche, first baby. That's a little young, so let's do that. And then first degree relatives. Remember, mother, sisters, daughters. Grandmothers do not count. And the age of grandmothers too, because remember, age is one of the biggest determinants of developing breast cancer. So let's do none, and let's put that risk, and then we'll go back in and change that. All right. So you have your 5-year risk and then your lifetime risk. When we're talking about these, it is basically looking at lifetime risk, and that's what you're going to go off of. So here's lifetime risk. So 13.6, remember that the average risk for most women is about 15%. That's that average risk group. So you can see there, after you plug it in, she kind of falls. Also, what it's bouncing off of is the average risk for what population you put in. So that's 14.4. So she's actually under what the average risk is. And then it just goes to tell you what you put in. So let's go that their yes was, if you do put that in there, so good to know. All right. Yes. So what's going to happen? It's going to tell you that you need to use another risk. So good. So let's go up in age. Let's do 50. So let's do 1, and we're going to see where that risk takes us. Okay. So there, now we have kind of gone into the area where this is probably going to be a moderate risk because we're over that 15, as well as she's almost 5 percentage points over the average risk for her age and kind of situation. All right. So you can see the difference. Really, the only thing that we really changed was ethnicity, and we changed how old she was. All right. So go ahead and play around with that. It's nice to put in some things to see exactly what they're kind of looking at. All right. So then you have the next group, 50 to 74, average risk, 50 to 74 years. Still recommending every 2 years unless there was something identified which would recommend more frequent breast imaging. You can see some studies there, age 75 and older. And that would be looking at life expectancy is at least 10 years. That goes on your prognostic ability, and comorbidities. And then, again, coming in at the 2 years. All right. All right, so that was breast.